Hello, everyone, and welcome to Tools and Lessons Learned in Addressing SRHR in Emergency Preparedness at the community level. We'll get started in 1 minute. We'll give everyone 1 minute to join the line before we kick off. But we did just want to flag that we are using a normal Zoom line today. So please do be sure to keep your microphones muted and your cameras turned off for the duration of the webinar. You can submit any questions that you have and that you think of over the course of the presentation into the questions and answer box, into the chat box. And finally, the webinar is being recorded, and we will be disseminating the recording to people who registered, as well as through other networks like IWAG. All right, Tashoma, over to the next slide, please. Tashoma, we lost your screen. Thank you. So the welcome again to Tools and Lessons Learned in Addressing Sexual and Reproductive Health in Emergency Preparedness at the community level. This is the third webinar in the technical webinar series of the Interagency Working Group on Reproductive Health and Crisis, or IWAG's sub-working group on emergency preparedness and resilience. My name is Lily Jacoby, and I'm a program advisor for sexual and reproductive health and research with the Women's Refugee Commission, and I co-chair the Emergency Preparedness and Resilience Sub-Working Group with Lorelei Goodyear of FP 2030. This webinar will introduce key tools to design and implement inclusive sexual and reproductive health and rights interventions for emergency preparedness at the community level, and will explore why community preparedness is essential for inclusive, sustainable response, and share lessons learned from community SRH preparedness programming in Pakistan and Nepal. Next slide, please. Our agenda today includes 3 presentations. Sandra Krause, Senior Director for Sexual and Reproductive Health of the Women's Refugee Commission, will present resources for inclusive community preparedness for sexual and reproductive health. Mala Shalise, Access Program Manager for the Family Planning Association of Nepal, will then present on FPAN's experience on community preparedness for sexual and reproductive health. And finally, Syed Tarab Ali Gilani, or Tarab, Program Manager for Renuma Family Planning Association of Pakistan, will address sexual and reproductive health within disaster risk management for health in Pakistan. We'll then have 15 minutes for discussion and questions and answers. And again, you can share your questions using the chat feature. We may not be able to address all questions during the webinar, but we will log those questions and we'll share resources and contact information so that we can all continue to follow up and discuss together. And my co-chair, Lorelei Goodyear, will then close the webinar with next steps. So I will now hand it over to my colleague, Sandra Krause, Senior Director for Sexual and Reproductive Health of the Women's Refugee Commission.
Thank you so much, Lily, and thank you all for joining the webinar today. So yes, I'm going to speak to resources for inclusive community preparedness for sexual and reproductive health, and specifically to a revised minimum initial service package for sexual and reproductive health distance learning module, for new community capacity and needs assessment tool, and a revised facilitators kit on community preparedness for sexual and reproductive health and gender. Next. So, but before I get into discussing those tools, I'd like to provide a little bit of context to why preparedness is essential for sexual and reproductive health response. Next. So globally, we know that the volume, length, and cost of humanitarian assistance is growing dramatically. 82.4 million people were forcibly displaced by conflict, persecution, and violence in 2020. An additional 30.7 million people were displaced by natural disasters. The Internal Displacement Monitoring Center also reports that the global cost of 1 year displacement in 2020, $20 billion US. And we know the global COVID-19 pandemic has resulted in hundreds of millions of people infected and more than 4.9 million deaths. So the UN Office for the Coordination of Humanitarian Affairs, UN OCHA, has reported 168 million people are in need of humanitarian assistance. Next. So emergencies and large-scale disasters have a significant impact on public health, health infrastructure, and the delivery of health services. Next. Emergencies also have a disproportionate effect on the most vulnerable, particularly women and children, but also other marginalized populations, such as people living with a disability, people living with HIV, people with diverse sexual orientation, gender identity and expression, and ethnic and religious minorities, among others. Next. So SRH needs do increase during emergencies related to disruptions in schooling, education, social and family support systems. There are increases in sexual and gender-based violence. There's a lack of access to health facilities, trained providers, supplies, and overall increases in food insecurity, malnutrition, and communicable diseases. So these result in increased risk of unintended pregnancy, unsafe abortion, transmission of sexually transmitted infections, and HIV, with the result of increases in morbidity, disability, and mortality, including for maternal and newborn. Next. So we know that sexual and reproductive health are needs in all communities, including in emergencies, but actions can be taken to prevent sexual and reproductive health related morbidity and mortality by the community in preparedness and response and in recovery. Next. So preparedness starts with communities. They are their own first responders. They are experts on their risk and vulnerabilities, as well as their existing strengths and resources. We also know that community preparedness activities are really most effective when community members and government bodies work together to identify and build on the existing capacities. Next. So preparedness is critical at every level, and efforts at the district and community level do need to be supported at national, regional, and global levels. And I'm really excited that Rob from Ranuma at FPAP is going to be presenting on how much work they have done at the national and subnational level to support their efforts at the district and community level. But just to note, at district and community level, it's important to integrate sexual and reproductive health into risk assessments and provide early warning for communities to identify and reduce SRH risk for vulnerable communities and support sexual and reproductive health services. So vulnerable communities, which I've discussed already, those who are often marginalized, adolescents, persons with disabilities, people with diverse sexual orientations and gender identities, and members of other marginalized groups. So just to note, this coordination collaboration, very, very important at all levels. And I did want to make a mention of the Sendai framework. The Sendai framework for disaster risk reduction from 2015 to 2030 was adopted by member states at the UN World Conference on Disaster Risk Reduction in Sendai, Japan. And the framework does call for increased attention to resilience and notes specifically how important health is to strengthening individual and community resilience. Next. So the first resource I'm going to discuss is a minimum initial service package for sexual and reproductive health distance learning module. In emergency settings, the IWAG had established in the mid-1990s a set of priority life-saving services to address sexual and reproductive health at the onset of humanitarian emergencies when there are so many competing priorities and needs in health and across all sectors. So these objectives of the MISP for SRH include ensuring that the health sector or cluster identifies a lead organization to lead the implementation of the MISP, to prevent sexual violence and respond to the needs of survivors, to prevent the transmission of and reduce morbidity and mortality due to HIV and other sexually transmitted infections, prevent excess maternal and newborn morbidity and mortality, prevent unintended pregnancies, and really from the onset to start planning for comprehensive sexual and reproductive health services, which should be scaled up within ideally 3 months of the acute onset of an emergency and integrated with primary health care, and that builds on the WHO's 6 health system building blocks. The other priority is to ensure that safe abortion care is available to the full extent of the law in health centers and hospitals. So the MISP for sexual and reproductive health was updated and revised in the Interagency Field Manual on Reproductive Health in Humanitarian Settings in 2018. Key revisions included a new priority objective on prevention of unintended pregnancy to ensure the availability of a range of long-acting reversible and short-acting contraceptive methods, and to be sure that the community is informed about the availability of these services at the onset of an emergency. The technical objectives of the MISP were all updated to WHO's evidence base, and there is now explicit reference to safe abortion care to the full extent of the law in the MISP, and it also is included as part of clinical care for survivors of sexual violence. So who is the MISP Distance Learning Module designed for? Really humanitarian and development actors working in health policy, management, coordination, and also working on emergency response teams. It's really relevant to providing information and education about these priority objectives and priority SRH services across sectors. So the MISP Distance Learning Module, the revision is very user-friendly, participatory now, and interactive. It takes about 5 to 7 hours to complete. It can be done in stages. It has each chapter of the MISP has a quiz at the end of the chapter, and at the end of the module, there's an opportunity to take a post-test where if users are able to get 80% correct, they'll get a certificate of completion. So it's a good way to kind of get feedback on knowledge about the MISP. So it's currently available in English, French, and Spanish, and coming soon in Portuguese, Nepali, Arabic, and Russian. So the next resource I would like to call your attention to is a Facilitator's Kit for Community Preparedness for Sexual and Reproductive Health and Gender. A little bit of background to this kit is that it's really a curriculum for 3 to 4 day training that aims to build the capacity at the community level to prepare for and respond to sexual and reproductive health and risk and inequities faced by women and girls in marginalized and underserved communities. So a little bit of background to this Facilitator's Kit on Community Preparedness. It was first developed in 2015 in collaboration with the UNFPA and local partners in the Philippines, where it was also piloted. Also used in piloted Northern Iraq, and most recently, again, Dhruv will speak to this, through a CDC supported initiative in Pakistan with Renuma. And this Facilitator's Kit was updated to address the revisions in the Interagency Field Manual on the MISP, which I've just gone over, and to integrate lessons learned from the pilots. I want to note, even though Dhruv is going to speak to this, I do want to note one thing that we learned from piloting in Pakistan is that we probably should have been more intentional, or could be more intentional and more systematic in our engagement of marginalized populations. So that led us to developing the community capacity needs assessment tools. So I wanted to mention that. And then I also want to note that this initiative was supported by the Foreign Commonwealth and Development Office of the UK, who supported a consortium called Approaches in Complex and Challenging Environments for Sustainable SRH. And as part of that project, consortium members, and a specific shout out here to FPAN, Open University, and IPPF were instrumental in supporting a new optional module on preparedness for epidemics and pandemics. Next. So the objectives of the Facilitator's Kit is really to have workshops that look at identifying SRH and gender risks faced by women and girls and other marginalized populations, provides a description of the MISP for sexual and reproductive health to participants, applies the knowledge of SRH and gender risks to the existing hazard and risk maps, identifies community level capacities and gaps for gender and SRH preparedness and response, and really it takes the findings from the community capacity needs assessments to the workshops to discuss actions that can improve preparedness for marginalized populations as well as the whole community, and related action plans with accountability mechanisms, M&E mechanisms. Next. So the Facilitator's Kit now includes these community capacity and needs assessment tools. A little bit more about them next is that they are designed to map the district's existing disaster management framework and links to national and subnational systems to understand health facility capacity to implement the MISP in emergencies, explore the community's definitions and understanding of resilience and the endpoints of recovery or building back better, to identify existing community capacities to respond to crisis, what needs strengthening, and the community's recommendations to achieve them, as well as to identify vulnerabilities and risk in the community, including specific subpopulations, and to ultimately identify priorities for preparedness or building back better. Next. So there are 4 tools. There is an interview guide for policymakers to be used with Ministry of Health and Disaster Risk Management representatives. There's a tool interview guide for health providers, and that is combined with a facility assessment tool with regards to readiness to implement the MISP for SRH. There's a tool designed for the community health workforce and community resource persons, focus group discussion guide, and then there's also a focus group discussion guide for community members themselves to be used with diverse community members. Next. Okay, so finding some of these community capacity needs assessments are then used to tailor use of the Facilitator's Kit in the community preparedness workshops to ensure they're inclusive and context specific, to ensure that the workshop and action plans address community members' identified needs, vulnerabilities, and priorities, and leverage existing resources and strength. So to identify existing emergency preparedness and disaster risk management structures and systems to be strengthened in the workshop and action plan. Next. So who should participate in the workshops? Well, disaster management representatives from Ministry of Health, disaster risk management agencies, protection agencies, program managers, policymakers, providers in the district and community, and definitely representatives from civil society groups and networks, and preferably those with some health background. Over the course of the workshop, participants in day 1 are, day 1 really addresses localized risks. So there's participatory activities to engage in the local risk and to explore SRH risk in those emergencies and building back better. Day 2 really looks at the MISP for sexual and reproductive health, those priority activities. Day 3 integrates localized risks, lived experience is kind of history, and also the sexual and reproductive health priorities. And day 3 then is really focused on action planning to prioritize initiatives to improve preparedness for sexual and reproductive health. And then there is a new optional module on examining epidemic and pandemic preparedness. The module's link is not a standalone module, it's definitely linked to the whole workshop. So that's why we say 3 to 4 days. Next. So I know you can't see this or read this, but I just want you to know that this theory of change is available on the website, and what it aims to do is to link the community capacity needs assessment tools with the workshops on community preparedness and to reflect outcomes and sexual and reproductive health outcomes and impacts. So that is available as a resource for anyone interested. Next. So together, these tools support communities to implement assessment of SRH risk, vulnerabilities, and capacities build knowledge and capacity of national, district, and community actors on sexual and reproductive health preparedness, response, and recovery, integrate sexual and reproductive health into health planning and coordination. Importantly, ensure that activities to support SRH preparedness are included within costed emergency and disaster risk management or health plans, and to ensure the sexual and reproductive health system, and SRH commodity supply chain can withstand local risk. So in closing then, I would just like to acknowledge the support of UK aid from the UK government, and also the Access Consortium, and particularly FPAN, the Open University of Nepal, and IPPF for the support of co-creating the pandemic preparedness module, and this co-creation process altogether really attributed to work done by the Access Consortium overall, co-creation, co-design, and contextualization, which Mala is going to be speaking to. So thank you very much.
Thank you, Sandy, for taking us through that presentation. Next slide, please, Tashoma. And I will, as Sandy said, now be passing over to our colleague, Mala Shalise, Program Manager for Access with the Family Planning Association of Nepal.
Thank you, Lily. Good morning, good afternoon, and good evening, everyone. My name is Mala Chadise, and I'm working as Access Program Manager in Family Planning Association of Nepal. Today, I'll be reflecting on FPAN's experience of co-creating SRS preparedness tools. But before I do that, let me quickly take you through a brief introduction of FPAN and also Access project within which the work around community preparedness for SRH is situated. FPAN is one of the largest non-profit making NGOs in Nepal, which was established in 1959, and we have been a member associate of IPPF since 1960. We have a proud history of initiating family planning momentum for the very first time in Nepal, even before the government launched its national family planning and maternal and child health project in Nepal. Currently, we are working at 42 districts out of 77 districts in Nepal, and we deliver SRS services through 1,232 service delivery points. Next, this is just to give you all a quick overview of our geographical reach and SRH services that we provide. So as you can see, we are present all throughout the country, particularly in the Southern Belt. And with regards to SRH services, the services that we provide are in line with IPPF's integrated package of essential health services. Next slide, please. We focus on working with and for poor, marginalized, socially excluded, and underserved communities to ensure the access to quality SRS services. We particularly work with persons with disabilities, older populations, people living with HIVs, migrant workers, GBV survivors, as well as young people and people prone to living in the areas that are prone to disaster. So FPAN has been continuously advocating for access to SRS services and rights, and particularly for marginalized and vulnerable population, as a result of which nearly 88% of our clients are from key marginalized and vulnerable population groups. Similarly, we've been contributing significantly to National SRHR program with around 17% contribution in safe abortion services and 20% contribution in FP services annually. Now, let's just look at a country's vulnerability to hazard. Nepal is exposed to multiple recurrent hazard. The country falls in the top 20th list of the most hazard-prone, multi-hazard prone countries in the world. We do also have risk of climate change, earthquake and floods, and similarly hailstorm and avalanches. So these are all like annual festivals in Nepal occurring every year. So these events have taken a huge toll on lives and human suffering, especially that of women, girls, and vulnerable community members. Next slide, please. With regards to emergency preparedness initiative at national level, we participate in RS subcluster and also in SRS technical working group. FPAN have also pre-positioned RS kit, particularly in the time of 2015. Similarly, we do have emergency response team at the central and branch levels. And all of our branch managers and most of the service providers have been trained on MISP. We also provide training on referral pathways and psychological support to providers in branches in disaster-prone areas. Similarly, with our initiative in emergency response includes branches participating in local coordination mechanism during disaster responses and conducting integrated mobile SRS camp, and also engaging reproductive health outreach workers and distributions of relief materials. So moving on to the project, next slide, please. Next. Moving on to the Access project, which Sandra has already mentioned earlier. So Access was initially a 3-year project that is managed by Access Consortium, WRC being one of them. The program aims at co-creating innovative and right-based solution to enhance sexual and reproductive health and rights for most of the marginalized and underserved population in complex and challenging environments. The project has 4 focus areas, building resilience for SRH being one of those. The project started in January 2021 and operationalized in 10 districts in Nepal, from the Central Hills and Southern Terai, which are prone to natural disasters such as floods. Next. So let us take a closer look at different phases of the project, planning, co-development, and implementation phase one by one. So moving on, first planning phase, next slide, please. So the co-planning phase. Planning phase for Access really began in 2019, and in 2020, consortium partners, including WRC, had done scoping visit to Nepal. The scoping visit was really instrumental in understanding of the consortium members regarding the country context in relation to SRHR preparedness and response, and also identifying the existing capacities and gaps of government and non-governmental organization in effective SRH preparedness and response in the country. The visit also allowed to explore inclusivity of DRR and SRS policies to respond to SRHR needs. So with next slide, please. With this visit, the observation from this scoping visit was then used to inform Access program design overall, and also including community preparedness for SRS. Next slide, please. So moving on to the co-development phase, as Sandra mentioned, we have been involved in, FPAN has been involved in contextualization and translation of CCNA tools, Facilitator's kit, and also co-creation of pandemic module, which is again an optional module within the Facilitator kit itself. We've also co-developed change pathways for community preparedness and for sustained and inclusive SRH in emergency setting. Next slide, please. So I would like to take a moment to describe how the co-development process took place. So let me just describe this by sharing a concrete example of how we contextualize Facilitator's kit. So we decided to review the Facilitator kit for contextualization. We started off by sharing FPAN's expectation from the review of Facilitator's kit. Based on these expectations, then guiding questions for review process was co-developed, and then planned with WRC and the Open University, who was providing technical support during this process. After this, each week for 4 consecutive weeks, FPAN and WRC independently reviewed the Facilitator kit offline and met online to discuss the gaps identified in relation to contextualization and possible ways to address these gaps. The Open University provided technical input into the weekly coordination meeting, and at the end of the contextualization process, review of FPAN's co-development expectation was done to assess if these were fulfilled, and the process was led by WRC, and as I said earlier, the Open University provided technical input into the process. Next, please. The co-development process was very much helpful for FPAN in getting oriented and acquainted with the tools itself. For instance, community capacity and needs assessment in relation to SRHR preparedness was an entirely new concept for FPAN. The process of contextualization provided us opportunity in understanding the concept and contents of the tool, as well as critically assessing the tools to evaluate if, how, and where these tools could be, fitted to the Nepalese context. So this obviously led to the ownership of the tools, and also needless to say that these tools were developed and updated to reflect the in-country context and needs. For instance, the need for developing pandemic tool to enhance community capacity for SRH and gender protection arose when Nepal was hugely impacted by global pandemic, COVID-19 pandemic, but also when the pandemic had disproportionate impact on SRH of women, girls, and other marginalized population. And with this, we believe that there's a strong likelihood for these tools to be uptaken nationally and subnationally. Next slide, please. So the implementation phase, so as we were approaching towards the end of implementation phase, the project couldn't be carried forward, but we hope to have further funding opportunities so that the work that has been done can be taken forward. Next slide, please. So these are the dissemination plans that we have. Thank you so much. And sorry, this is, yeah, thanks. So as a next step, WRC and FPAN is looking for further funding opportunities, and we've already started working on a project where we are trying to strengthen the inclusion of older persons and persons with disabilities, disabilities in community preparedness for SRH in Nepal through IDLA Humanitarian Innovation Fund. Thank you so much.
Thank you, Mala, very much. Next slide, please. And we will now be handing it over to our colleague, excuse me, Tarab Ali from Ranuma, the Family Planning Association of Pakistan, who is presenting on behalf of Dr. Anjum Rizvi, the Program Director, on addressing SRH within disaster risk management for health in Pakistan. So Tarab, over to you.
Thank you, Lily. Next, please. Thank you. Now, Pakistan is one of the most disaster-prone countries in the world. It is a large country with around a 790 square kilometer area. Over, I think, so 26 million people is here. It is a country with a great topographical and a climate contrast. It has a kind of a topographical features from a coastal beach, sandy deserts, peatless, fertilized plains, high mountains, and snow-covered of glaciers. One of the largest river system, that is Indus, runs through a length of Pakistan. Therefore, we are faced with a number of hazards, including floods, earthquake, and landslide etc. So, next, please. Overall objective to build the evidence-based and the tools of incorporating of SRH in DRL communities affected by crisis in Pakistan. This is funded by CDC, WRC, and Dissemination as well as FPAN implementations, a 5-year project to build the evidence-based and tools for incorporating SRH into a DRR for communities affected by crises in Pakistan. Specifically, the objective is to be build community to level health workforce to prepare and respond to SRH risks using the WRC and UNFP facilitators, community preparedness and reproductive health, and the gender and established supporting and the coordination environment for community level action on SRH in Pakistan. And the second is the development of the evidence based on a tools the incorporating SRH into disaster risk. The previous. Yes. Second objective is to develop the evidence-based and the tools that incorporate SRH into disaster risk management for health for communities affected by crisis-based and achievement and lesson learned for the year piloting to the WRC and UNFP facilities in Pakistan. And the third Our specific objective is as to scale up to interventions for SRH integrations with the disaster risk management for health. It is institutionalization and inclusion of SRH into existing disaster risk management efforts among specific community-based stakeholders. Next, please. Yes, we are going to be moving closer to practice through empowering the providers and communities to scale up of the buildings resilience for SRH community of level. This is the 5 years grant from the CDC and Control Prevention and the Women Refuge Commission, WRC, and RFP implement partnering here in Pakistan, RFP to develop close coordination with Disaster Management Authority and Provincial Disaster Management Authority and District Disaster Management Authority and other to engage a parliament public department, held RH working group meetings at a federal and provincial level and as well as national levels. And others to conduct community levels training to the selected union councils in the 3 district crisis affected Khyber Pakhtunkhwa, Punjab, and the Sindh provincial as well as to conduct the trickle-down trainings with public and private department, including rescue 1122 Pakistan Emergency Service around community members. At the community level, Family Planning Association Pakistan conduct community level trainings in the selected union councils, which I already mentioned. Next, please. I have this is the NDMA structure. Disaster management is the main authority in Pakistan. Is the main structure of NDMC, Nation Disaster Management Commission is here. NDMC, Nation Disaster Management Commission is a trickle down on the NDMA, Nation Disaster Management Authority, and it is working at the national level, and the second is the provincial level. PDMA, Provincial Disaster Management, is a trickle down on the district level. This is the grassroots levels effective on PDMA as a District Disaster Management Authority working on the grassroots level. Next, please. Yes, FPAN is implementations in 3 provinces, Khyber Pakhtunkhwa, Punjab, and Sindh, and working in the 3 districts, Nowshera, Muzaffargarh, and Badin, and which is Union Council Pisabad, Nowshera Kalan, Choki Mamrez, Union Council of Doaba and Radabad, and other Union Council of Talai. Next, please. Yes. It is a program interventions community priorities through action plans during the community training. Participants develop action plans for their respective uses, which I mentioned in last slide. The aim of address gaps to be MISP and SRH activities. We have developed a reference system for sexual and gender-based violence survivors through a mapping GBU services in the public and private sector through the close liking with the government stakeholders and have an influence of community in a community sensitization males. There are 2 groups, male and females, who have to be conducted community sensitizations in the field and have conducted a blood donors groups and established blood group to make a blood transaction and feasible to the emergency. Enhance the free availability of condoms, introduce birth planning to every pregnant woman in the UCs, and the strengthening transport available for emergency obstetric and the newborn care services. We have to do these the features we have implemented in these projects. Next, please. Then we have to get selected outcomes in Choki Mamrez in Khyber Pakhtunkhwa. The provision of SI services we have to be increased in young people, especially in young people, increase up to 17%. In Nowshera Kalan, Khyber Pakhtunkhwa, we have to be conduct medical camps in blood donors clubs was established and providing blood to the need people to be doing crisis emergency, even roadside accidents. In Doaba, Punjab, we have Facilitator to be transport group was created to provide transport of 6 and in emergency. In all of project uses, GB's reference system was developed and awareness provided to the communities for respond to GB cases and reference provided to the appropriate services. Next, please. major achievement we have to begin regarding this project at the national level. It is a achievement of our in a national levels. We have make a memorandum of understanding was signed between NTMA and Family Planning Institute of Pakistan, integrated the MISP into a DRR and disaster risk management affair. This partnership was trickled down effect to the provincial and district levels. It was more effective in a community level to be conducting the MISP trainings in national levels and provincial levels. The MISP has been integrated. Also be in a rescue. 1122 is a community response team activities. 1122 is a emergency response teams. There we have provided a green delivery kits are placed in rescue. 1122 emergency services is also. Next, please. Yes, in this program, we have reflection and lesson that investigative preparedness is both beneficial and stable time and for emergency and crisis. During the trainings, we have making an action plan causing highlighted gaps in a critical SRH services, including response services and GB survivors mechanism to identify pregnant, especially in pregnant women and referral cases and develop and transfer to the authority in emergency. And also we have provided training in SRH, enhance the quality services to provide provisions and community level awareness, raising directly to take of SRH services in our activities, and also creating a demand for SRH services in advance for emergencies. Next, please. A clear vision plan and coordination with the RH working group and across sector, as well as direct involvement of relevant government agencies, including the NDMA, PDMA, and DDMA, have been integral part of the building resilience and securing political and financial support for community driven efforts. And identification and utilizations of local response are critical to be building community capacity and ownership. The project has highlighted the need activity facilitation to greater inclusion, marginalized and underserved populations in the community action planning process. This would be better ensure to be those the most vulnerable included in all aspects of the building community resilience. Please, next, please. Next. These are some photo clips during health camps and communities. Next. Yes. The program interventions of way forward, IPPF and animal Americans will continue to be a sustained preparedness initiatives with the support of Australian government is also in a pipeline. RH working group needs to be extended to be support in urban community affairs. And partners during the trainings intend to share experience and learning from this project to continue advocating for institutionalization of SRH into disaster risk management report at global and national levels. Thank you very much.
Thank you very much. Tashoma, over to our next slide. Thank you. So we are now into the discussion and question and answer section of our webinar today. And our first question in the chat, and as a reminder, please feel free to insert and input any questions that you might have using the chat function. The first question that we have is, I believe, for Turab, and indicates interest in knowing more about strategies adopted to engage men during community preparedness for SRHR and family planning, and what were some lessons learned on engaging husbands in family planning, either in distribution of contraceptives or in other ways.
Yes. During the, we have working on a grassroots level in the communities, and we have conducted more sensitization sessions in community in the three districts, Nushaira Killa and Muzaffargarh and Badin, district Badin, Sindh. So a lot of people in the community to intend that this is the very helpful and most helpful to be implemented in the future for awareness of SRH problems to solve on community basis.
Thank you, Turab. Our next question is for Mala. And that question is, what would your advice be to practitioners that are interested in using these community capacity and needs assessments and facilitators kit for community preparedness for sexual and reproductive health and gender tools?
Thanks, Lily, for the question. So as I mentioned earlier, that one of the challenges that we have in Nepal is that SRH is not prioritized even in a disaster preparedness plan and response plan, and also that the integration, even if there's a preparedness plan at the district level, the integration of SRH into the preparedness plan is not that quite pronounced. My advice is to for all the disaster preparedness agencies and program managers, health program managers, is to make the use of the CCNA tools at first, because this tool will help us identify the existing needs and priorities as well as capacities of the key marginalized and vulnerable populations with regards to SRHR preparedness. So then linking the evidence that has been obtained or the gaps that has been obtained from the community capacity needs into planning the preparedness plans specifically around SRHR. So yeah, thanks.
Thank you, Mala. And Tarab, I'd like to pose the same question to you as well. What advice you would have for someone interested in using these tools and resources based on your experiences implementing?
During our training and sessions in the community, we have developed a reference system for sexual and gender-based violences and survival through a mapping SGB services in public and private sectors, and also we make sensitizations with males and the Khyber Pakhtunkhwa are very rigorous areas where we cannot be talk openly on SRS services, but we have to be sensitized the community at community level, and we have to make a blood donor groups and make a blood transfusions feasible to the emergency to be developed and enhance the free availability of contraceptives that at there introduce the birth planning to be every pregnant at UCS levels. Yes, please.
Thank you, Tarab, very much. My next question is for Sandy. And that question is, what do you see as being key challenges for bridging the gap between humanitarian and development sectors for SRH preparedness? And in conjunction with those key gaps, what you would consider to be best practices for working to bridge that gap?
Thanks, Lily, for your question. Good one. I think, in both of these efforts by FPAN and FPAP, we had successfully worked together, both development and humanitarian agencies, so that technical guidance on the priorities in an emergency was provided from the humanitarian side, which is compared to comprehensive reproductive health in the development sector. It's limited and it's minimal, but it's critical that development actors have a good understanding of the priority activities at the onset of an emergency. And they are the actors on the ground, working day in and day out with the government and communities themselves. So they're best positioned. So the challenge really is that communication, but I think we were able to overcome it in both the planning in Nepal and in Pakistan. It seemed quite natural that we provide some technical information and support. And I do think, even though the priorities of the MISP are not difficult, they're very limited, it's still, if you're a development agency and you're used to providing comprehensive reproductive health, it can be a challenge to focus on a limited set of priority activities. And that's what we found in the project in Pakistan. For example, the MISP includes preventing and providing care to survivors of sexual violence. So it's very specific. It's different than broader gender-based violence. But you see, when you heard from Tarab, that in Pakistan, They developed referral mechanisms for survivors of sexual violence in every one of the projects, and having those in place prior to an emergency only affects things as well in stable times. So I think the good news here is that preparedness activities do improve things in stable times. So I think the challenges can be overcome, most certainly, and we do need, I think, that development actors to own and support preparedness initiatives and building community resilience.
Thank you, Sandy. My next question is building a bit on that for Mala. And Mala, I was wondering if you could speak to some of the broader emergency preparedness and response initiatives that FPAN has underway or has taken on historically, including those integrated reproductive health camps in humanitarian settings, distributing kits, rapid response teams, and MISP trainings. And I'm curious if you could speak to one or two key lessons learned from what has been effective for moving those initiatives forward, and what types of impacts you've seen for FPAN and in the communities you serve as a positive result of those preparedness activities.
Yes, Lily, thank you for the question. And as I already presented as I already discussed in the presentation, one of the important preparedness activities that we have been doing is conducting MISP training to all the FPAN branch managers and service providers, not only to the service providers, but also to key vulnerable populations. So that has been one of the key preparedness activities that we've been doing. Apart from that, with regards to response, as you said, we've been conducting the mobile camp or the RON camps in the disaster affected areas. So recently also, when there was a disaster that happened in Nepal, we had conducted the camp where we provided MISP, including other services such as lab services and FP services. Those services were provided, and from FPAN's experiences, these camps are really helpful for the disaster affected communities in accessing SRH services. So apart from that, we've also been distributing RH kits, and recently we prepared RH kits and then distributed it to the disaster affected community, and the feedback obtained from that distribution was also very well. These are a few of the preparedness as well as response activities that we've been doing from FPAN's side. Yeah.
Thank you, Mala. My next question is for Tarab. And Tarab, I'd like to ask if you could speak to what, if any, impact you saw on the SRH response or the SRH components of the response to COVID-19 in Pakistan, and if you felt that the preparedness activities that had been undertaken as part of this project prior to the onset of COVID-19 impacted the way in which the response unfolded.
Yes, it is during the last year in 2020, when COVID spread all over the world and especially in Pakistan. It was very helpful and impact the MISP trainings in a community and as well as an emergency response organization, just I have said and described in 1122. We have provided the SRH kit during that time in emergency. They have utilized in emergency because before this training, they did not to be able to be any procedures or any subjected to be developed during the training. So this way, it was very helpful in COVID situations, and in emergency, they have utilized the SRH kit is also we have provided with the help of humanitarian. And we have also been provided COVID kits in a community where we have to be made in field in both provinces, Punjab, Sindh, and KPK. Yes, please.
Thank you, Turab. And for our final question, we will pose this both to you, Turab, and to Mala. But Turab, I'll start with you as you're already on the line. Could you speak to how, there's been much attention paid to localizing approaches to emergency response and to emergency preparedness? And we would like to ask if you have feedback or recommendations from your experience as an implementing partner on the ground for how the localization approach can be strengthened for emergency preparedness for SRH activities and programming.
Yes, we have provided the technical assistance and support to the communities in project areas, and approached and integrated to other projects, which we have to be mentioned in our slides, and we have to be accessed and reach the 80% of our SRH activities from those restrictions, make an action plan in the communities and implement in the time-letting and within time-letting and reported period. And we have already been discussed on and established with the working with the RIW meetings on regular basis on provincial level, national level, and district levels. Yes, please.
Thank you very much. And Mala, over to you to speak to any recommendations that you have for successfully operationalizing a localized approach to emergency preparedness for SRH.
So speaking of the context of Nepal, I think the first thing that we should start with is making, the health service health policymakers, disaster management agencies, and program managers aware that SRH is an integral part of, should be an integral part of the disaster preparedness and response plan. And I think with that, the advocacy should also happen at national and subnational level in order to include SRH preparedness, in order to integrate SRH into the national and subnational preparedness and response plan. So that's one of the recommendations that I would have. The other thing that the other recommendations in terms of localizing the preparedness activities, I would say, would be to enhance, build the capacities of the disaster management agencies and our program managers, and also the marginalized and vulnerable populations on ground that has the likelihood of being impacted disproportionately by disaster in building, in identifying their needs, and also the ways of potentially taking that into consideration and addressing that into the disaster preparedness and response plan. So that these would be my recommendations, Lily.
Mala, very much, and thank you all for your questions, and to our presenters for their rich feedback. I am now going to take us on to the next slide, and we will be closing out the presentation with a discussion of next steps for attendees around how they can engage in emergency preparedness for sexual and reproductive health. So I will be passing over to my colleague, Lorelei Goodyear of FP 2030, who co-chairs the Emergency Preparedness and Resilience Subworking Group of the IWAG.
Thank you, Lily. For those of you who want to take action to advance emergency preparedness and response for SRH, there are 3 additional guidance documents that enable governments and NGOs to plan and implement strong EPR commitments and strategies. Next slide. First, we have last year around this time, we launched the Ready to Save Lives Preparedness Toolkit, which, like today, provides case studies from around the world on developing policy, strengthening supply chains, and using inclusive approaches to advance EPR. There are over 40 different resource documents that you will find listed in this. So that's sort of a treasure trove of information about how to get started on preparedness. The second document is really designed for countries that are making FP 2030 commitments. And we offer guidance on incorporating EPR into those commitments. And this guidance is based on the high impact practices strategic planning guide for family planning and humanitarian settings. And last, IPPF led on the development of the MISP readiness assessment that enables stakeholders to develop an evidence-based plan of action to become prepared to meet SRH needs when a crisis occurs. And I think somebody's putting in the chat a link to the commitment guidance, which has links to the other two documents. Next slide. For those of you who want to share your knowledge about working on preparedness and to advance the emergency preparedness and resilience agenda, I would invite you to please consider joining the IWAG EPR sub-working group. Our next meeting is Tuesday, November 2nd. There's a link to that in the chat. This year, we've primarily focused on promoting preparedness tools and approaches, but at our next meeting, we'll kick off a discussion on the relationship between preparedness and resilience and what the working group can do to advance resilience at health system, community, and individual levels. In closing, I want to thank the Women's Refugee Commission for organizing today's thought-provoking webinar and for their leadership on advancing EPR for SRH at global and community levels. Since its founding, WRC has always found ways to bring the voices of women and girls to policymakers to drive policy change that reflects their needs. Many thanks to Sandy Krause of Women's Refugee Commission, Mala Chalise from FPAN, and Tarab from Ranuma FPAT for offering such valuable lessons on how to advance community preparedness using inclusive practices. And thanks to Lily for facilitating today's discussion. As a saying goes, success favors the prepared. We hope that the tools and experiences shared today will help you become prepared to meet the critical need for SRH care in emergencies. Thank you for joining us.
Thank you, Lorelei, so much for taking us out, and thanks to everyone who joined us today. We were not quick enough on the draw to get those resources into the chat, but we will include all of the relevant links and information for all of the resources discussed today, and the information about the Emergency Preparedness and Resilience Sub-Working Group in emails that will go out after we've wrapped up the recording and started disseminating the webinar, so we can all continue the conversation. Thank you again all very much for your time, and please have a good rest of your day or a rest of your evening.